Thank you everyone for coming. Welcome to the second webinar of our Hit the Road Hep C and Don't Come Back No More webinar series. This is hosted by the Physician Learning Program and the Office of Lifelong Learning in collaboration with the Edmonton North Primary Care Network. So my name is Panita Tandon. We met last week. I'm a liver specialist and a medical director at the Office of Lifelong Learning and the Physician Learning Program. And for those of you who aren't aware, the PLP creates actionable clinical information by engaging, like we are today, with physicians, teams, partners, and patients to create sustainable solutions to advance practice. And the PLP is very dedicated to moving evidence into practice, fostering a culture and an environment where everyone works together to tackle our most pressing problems, including important topics such as the one today. For the land acknowledgement, we acknowledge that we're on traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked this land for centuries. And just some brief housekeeping information. Please use the chat feature if you have a question about technical difficulties or L3 programs and services. And if you have a question for Dr. Rose, please use the Q&A feature of the webinar. Please review what's already been asked and upvote those questions. And Dr. Rose is going to try his best to answer all of the questions, but we can't guarantee that we'll have time to do that. And lastly, a recording of the webinar and a Pearls of Practice is going to be sent via email to all those that registered after the second session. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. You can get more information at the QR code. And of note, the activity has not been formally reviewed by the CFPC or the Royal College, but it is, of course, eligible for non-certified credit. And Main Pro Plus participants can also earn additional certified credits by completing a linking learning to practice exercise. So with that, I am going to introduce again Dr. Matt Rose, and the topic that he's going to provide us today is managing referrals in primary care. Dr. Matt Rose is a family doc, a clinical professor in the Department of Family Medicine at the U of A, and associate medical director at the Radius Community Health and Healing, which was formerly the Boyle Macaulay Health Center. He serves Edmonton's inner city, and practice interests include primary care for those living with substance use and addictions, HIV, hepatitis C, as we'll speak about today, ethical and social issues involving marginalized populations. So thank you so much. Thank you, Dr. Rose, for coming back for week 2. And I'll see you guys at the end for questions. Over to you.
Great, thanks. Thanks for that introduction, Dr. Tandon. And I am pleased to be back. I'm going to share my screen here. I just have to. Oh dear. Here I was all very organized until I'm not. But while I'm figuring out what on earth I'm doing, let me just very quickly summarize what last week's bottom line was. Hepatitis C is on the road to being eliminated. The goal is to have it eliminated as endemic infection worldwide by 2030. But what we are in fact looking at achieving is, Alberta in fact is on track. The key message is screen everyone. If you're not sure if people have risks or not, or if they're not sure, screening is always a good first step, and there will always be others who, including specialists, who will be able to help you sort things out. I'm sorry about that here. I thought I was so. Let's see if I'm getting what I want here. Here we are. Okay, I think we're good to go. Yay! All right. Here we are. Okay, I'm going to, instead of start on the last slide, I'm going to go. All right. Okay. First of all, yes, my disclosures and potential conflicts of interest. I do talk to pharmaceutical company representatives. I don't take money or other incentives from them. And the other thing is I work with a very specific population with a lot of addiction and social issues. And so I see the world, particularly the world of primary healthcare, through that lens. We have 3 objectives today, which I hope this will help us achieve pretty effectively. Number 1 is determine why and when a referral is needed and where a patient should be referred. Number 2 is having some idea of how to discuss the basics of treatment with your patients, and then also arranging a follow-up plan, whether or not treatment is part of that. And then part of that is recognize which patients require more intensive follow-up. So here are some basic statistics, and there will be an exam afterwards, so pay attention. So 2 to 6% of people with chronic hepatitis C will develop liver cancer each year. There are approximately 260 or 250,000 people living with hepatitis C in Canada at the moment. So that means every year, well, there'll be a significant number. The general incidence of liver cancer for all causes is 0.01%. So there's a fairly big difference between all cause of liver cancer and hepatitis C related, or your risk of developing liver cancer if you have hepatitis C, compared to the baseline. The other thing is, as far as Hep C and cancer are concerned, is people with hepatitis C are 2 times more likely to develop a lymphoma. And I've had a few patients who have developed lymphomas after treatment, having successfully cleared hepatitis C and so on. So it remains a risk as far as we're aware. But interestingly, people with chronic HCV are not more likely to develop other types of cancer than those without in general. So liver cancer and lymphoma are definitely the 2 cancers most closely associated with hepatitis C. So it is time to test your knowledge. So people with hepatitis C are how much more likely than the average person to develop liver cancer? Just throw it out there. Don't worry about being wrong. The important thing is in fact, my theory is if you're wrong, you're more likely to remember the answer when you're corrected. Certainly that has been my experience as a practitioner. Just saying, but this is not all about me. Okay. All right. So in fact, so we're looking at have people think you're about 2 times more likely to develop liver cancer than the average person. And then the rest is more or less equally spread. In fact, oops. So okay. So let us. Oh, there we are. Sorry. It is in fact 2 to 600 times more likely, because the annual incidence of liver cancer in people with chronic Hep C is 2 to 6%. The annual incidence in the general population is 0.01%. I'm messing around with the stats a little bit. It's not exactly that, but that you're looking at a hugely different risk of developing liver cancer. So that is very important, because if you've had hepatitis C for decades, well, for every year you have hepatitis C, your risk increases. It is associated very closely with development of cirrhosis and other changes in the liver, which are related to hepatitis C and a few other things. So a bit more complicated, but the bottom line is much higher risk than the average non-HCV infected person of developing liver cancer. Successful treatment of HCV reduces the risk of developing liver cancer by 75%. So you're still 50 to 150 more times more likely to develop liver cancer better than 600 times. I'm put into the context of Medivir 0 to 1. So that's a little, as I said, what is important in gauging how much at risk people are of developing liver cancer has very much to do with the damage that hepatitis C or other factors, including alcohol, have done to the liver. The more, and liver scarring is called cirrhosis. The more advanced the cirrhosis is, the greater your risk of developing liver cancer. Medivir is it's a scale that's used by ultrasonographers to assess the amount of, and maybe it's also used in biopsy. But anyway, it is zero. A Medivir score of 0 indicates really no noticeable change to liver cells or architecture, and it goes up to 4, which is advanced cirrhosis. People who have a Medivir score of 0 to 1, which is many of the people that we see with chronic HCV, are probably, after clearing HCV, so through successful treatment or spontaneous clearance, are probably no more likely, or not much more likely, than the average person to develop liver cancer. So this is a good reason to treat hepatitis C, because you're not only getting rid of the hepatitis C, you are also significantly improving people's chances of never developing cirrhosis or hepatitis C. Once people get into the 3 to 4 range in the Medivir score, then their risks remain high even after treatment, and they do require some ongoing monitoring, which I will briefly refer to. So hepatitis C, hepatitis C causes damage to liver cells, resulting in cirrhosis. That's its main action that causes morbidity and mortality, ultimately mortality. So, but cirrhosis in general contributes to 1 in 50 deaths worldwide. There aren't too many things like traffic accidents, cancer. So this is not, the occasional alcoholic gets cirrhosis and dies from it. No, this is a significant public health issue. It does take years and years for cirrhosis to develop as a result of chronic HCV infection. That is, of course, variable. But bear in mind that many of the people that we may be screening will have had hepatitis C for decades, particularly if they're from the at-risk groups of those born in the 50s and 60s, where the prevalence is slightly higher in those groups for some social factors, including behaviors as younger adults. So the sooner the sooner HCV is detected and the sooner it can be treated, the less damage will be done to the liver, and the better able you will be to avoid developing cirrhosis. So in North America, this is pure guess. What's the leading cause of cirrhosis? Is it Hep C, Hep B, alcohol, or non-alcoholic fatty liver disease? Okay. So a little over half think it's alcohol, and the other 2 split between hepatitis C and non-alcoholic fatty liver disease. So let's see what we, oops. Pish. There it is. Okay. The answer is stop moving around. It's my mouse is biting me on the, okay. It is in fact hepatitis C, not including Mexico. So Mexico is part of North America, so I do kind of lie. But I think this is I would have got this wrong prior to doing my research for this presentation. It is hepatitis C, and we have within our practice lifetimes to eliminate hepatitis C as an endemic infection and take a huge chunk out of the amount of cirrhosis and consequently liver cancer and all the attendant harms related to Hep C liver disease. I'll also put in a shout out to all of those who are interested in treating alcohol use disorder. We need to be doing a better job of that too, but I will not harangue you about that. That's not my goal today. So, what are the reasons for treating hepatitis C? To reduce the risk of cirrhosis, which will then reduce the risk of liver cancer, as well as eliminate the risk of transmission to others, for an ultimate goal of elimination of endemic infection, which will also reduce the prevalence and incidence of cirrhosis and the prevalence and incidence of liver cancer as well. So lots of good reasons, not just from the individual patient's perspective, but from a public health perspective, saving the system millions and millions of dollars. Okay, so here's another question, and I think this should be, if you tuned in last week, you should be able to get this one. So which most accurately reflects the current state of HCV treatment? People previously untreated must undergo treatment with PEG interferon ribavirin regime before being considered for the direct acting antiviral, which is the pill only regime. Previously untreated must undergo retreatment with PEG ribavirin before DAAs, or you guys are so far. Those previously treated with untreated HCV should be treated directly with a DAA, and people previously treated for HCV are not eligible for treatment with any of the HCV treatments. So if you haven't had Hep C treatment before, you have to do the PEG interferon. If you have been previously treated, you have to retreat with PEG interferon before the DAAs. You can skip all that and go directly to DAA. But if you have been treated before, then you're not eligible for anything. There was a bit of hemming and hawing going on, which is fair enough, because this is not, and to sort of navigate my overly complicated grammar here makes it a bit challenging. All right, let's see what the results are. So there we go. Most people, 3/4 of people, are saying go straight to the direct acting antiviral, the single or the one type of pill regime, the once daily treatment. And in fact, that is the answer. So if you haven't been treated with if you haven't been treated for hepatitis C, you go directly to a direct acting antiviral. A bit of a red herring there was people previously treated for HCV are not eligible for treatment with any combination. That isn't in fact the case, but it does become more complicated when people have been previously treated. If they have been treated without viral clearance, so a failure of treatment, less problematic, particularly if it's a PEG interferon regime that they've been on in the past. If they have been treated with a DAA and then it is reinfection rather than sort of recurrence or unsuccessful treatment, then it becomes a bit trickier depending on who's providing coverage, and Alberta Blue Cross is not the most generous when it comes to those sorts of things. Okay, oops, here we go. So the direct acting antivirals occasionally have side effects, but several orders of magnitude less than pegylated interferon ribavirin treatments, which were murderous, almost literally. Most common side effects include headaches, sometimes some pretty bad headaches. I've seen a rash. Uh, as with any medication, GI upset is one of the more common side effects. But 5 to 10% of people will experience these things at most, and in almost every case, they diminish over the first couple of weeks of treatment. So most people are able to tolerate this very well. If any of you had patients who are on the pegylated interferon and the ribavirin-based treatments, people were just sick for months, 6 to 12 months. It was a miserable thing to put people through. And this is the DAAs have really changed changed the landscape entirely. So the few of the advantages, so fewer side effects or less intense, as I mentioned, a much shorter duration of treatment. So the treatment duration is 8 weeks to 12 weeks, depending on the medication that is prescribed, and has much higher rates of viral clearance. To put it in a bit of perspective, you could with pegylated interferon, with the peg ribavirin combinations previously, you could expect clearance rates, if you were really lucky, of about 80% for some genotypes, as low as 50% for others. With the DAAs, it's 95% plus. I mean, anybody who takes their medication exactly as prescribed is pretty much guaranteed a cure unless there's something weird going on. One example I have, one of my patients who has had a fair amount of his gut removed for Crohn's and has the short bowel syndrome and rapid emptying. He has an ostomy and so on. We think the ID specialist involved thinks that maybe it was just the medication was moving too fast through his system to be adequately absorbed. So it's very rare. Everyone else that we've treated has had clearance, and there's some interesting data showing from marginalized or at-risk populations where people's adherence, because it's a once daily dosing for basically most of the regimes that people would certainly start on. And sort of in higher risk populations, people who are still using IV drugs or people whose social situation is generally unstable, that if you've got 80% adherence over the course of treatment, your viral clearance is pretty much the same as people who have 100% adherence. You're even getting good, like 70 up to 75% clearance with people who are adherent 50% of the time. This doesn't mean it's that we encourage people to take it when they feel like it. No, it is very much the more you adhere, the more consistent you are with taking your medication, the better your chances. And the way I phrase it for my patients is I say, if you buy a lottery ticket every week, your chances of winning the jackpot are better. With hepatitis C, if you take your pill every day, you're guaranteed to win the jackpot, which is a cure of hepatitis C. Yeah, so that is exactly what I said. So these are your patients, and it's a clinical scenario, and there will be a question. So 40-year-old male, immigrant from Egypt. His mom was recently diagnosed with and treated for HCV. Egypt setting the standard worldwide for how we should be dealing with hepatitis C. And this fellow recently came in, and that's a few months ago, because his mom had told him about this. So he got tested, found out antibody positive, reflex testing, and came back positive for RNA. He is currently drinking 6 to 12 regular 12-ounce beers per day. How do you proceed? So what's your goal here? Whoops. Oh no, I've given away the answer. There we go. Okay, let's try see if we can do this right this time. Okay, so what's the primary goal here? First, to diagnose, do an assessment of the alcohol use, decide if it's an actual alcohol use disorder or if it's just unhealthy drinking. Do urine testing to check for other substance use, treat the hepatitis C, or do an assessment of liver function. What's your primary goal? What's the first thing you want to do? This is tricky, I will have to admit. Okay, so treatment. Okay, excellent. So people are, 80% of people are saying, okay, treat the hepatitis C. Absolutely. Let me explain why that is. Okay, stop this. The reason for understanding the alcohol use disorder is it is a condition, if that's in fact an active health issue, then it is also a health concern that needs to be dealt with because it will cause morbidity and mortality on its own. The other consideration around alcohol use disorder is if the alcohol use is bad enough, it may actually interfere with adherence to medication. So that is a consideration. But alcohol in and of itself does not likely interfere with the effectiveness of DAA, direct acting antivirals. And alcohol and hepatitis C, when alcohol and hepatitis C are both present, their effects on the liver are not 1 + 1 = 2, it's 1 + 1 = 10. So getting rid of one of those, if not both, is going to be your best bet for reducing risk. So people actively drinking is not, it's not an absolute contraindication to treatment. And in fact, talking about hepatitis C and the interaction with alcohol and so on can be a really good place to start that conversation about alcohol use and whether people think they should be making changes in that regard. Urine drug testing for other substance use, meh. Is it going to change how you approach things? No. An assessment of liver function, that may affect things if people actually have pretty advanced changes to the liver, including cirrhosis, in which case since my bottom line is, as a primary provider, most of us are not going to directly treat, we're going to refer. So that kind of thing will be, as part of the workup for treatment, it will be assessed. And so really, where are you going with this? You're going toward treatment, and that's what you're going to tell your patient. You're going to say, you have hepatitis C, let's treat it and get you cured. So here's a different scenario. So you got a 60-year-old lady with ultrasound evidence of significant cirrhosis, but no lesions on, nothing suspicious on the ultrasound. She has some stigmata of active liver disease and cirrhosis, and she has chronic hepatitis C. She drinks no alcohol, on a bunch of different medications for diabetes, hypertension, hypercholesterolemia. So in this situation, to whom should you refer? First and foremost, infectious diseases, hepatology, an alcohol treatment program, or general internal medicine. Okay. Well, 2/3 are saying to hepatology, 1/3 to infectious disease, more or less general internal medicine. In fact, they're all correct except the alcohol treatment program because she's not drinking. And I put that in there because I have seen referrals to alcohol treatment for people with cirrhosis who are not drinking and haven't been drinking for years. It's strange, but it is what it is. Really, hepatology, your best, because there's cirrhosis there, significant, and it's going to need to be managed. But if you send them to ID or general internal medicine, chances are they will involve hepatology anyway. The point is, refer this lady on because she does need treatment, and she's a lot more complicated than any of us in the primary care level would normally deal with. So, third and final clinical scenario. So this is a 38-year-old male treated for HCV with direct-acting antivirals. He achieves a sustained viral R. What is that? SVR. I have no idea what I was writing. SVC is sustained viral clearance. 12 weeks after treatment 3 years ago, i.e. cured. Denies IV drug use, and he quote unquote only smokes his drugs now. ALTs are significantly above normal the last few tests after being less than 20 in the years prior post-treatment. So his ALTs are going back up. In this situation, you should accuse of illicit substance use, repeat an ultrasound, repeat the Hep C antibody screening, repeat the Hep C RNA, or repeat the ALT. Okay. So about half people repeat the RNA, half repeat the antibody, and a few people repeat the ALT. Okay. So the correctest answer is repeat the HCV RNA. This is someone who has a clearly established risk, at least in the past, of HCV acquisition, and even smoking drugs. There is a low, but still not zero risk of acquisition of HCV through pipe sharing and so on. Once someone is positive for a Hep C antibody, they will always be positive, and repeating that is going to give you no new information. You know that the ALTs are elevated. You might be reassured if you see the ALT drop below 20 again, but you might be falsely reassured because it is very possible for people to have chronic HCV and have ALTs in the normal range, although more often you'll see them elevated, but definitely not in every case. Repeating the ultrasound. Yeah, there are other causes of elevation in ALTs, which may have to do with alcohol use and so on, non-alcoholic fatty liver disease, etc. And accusing of people of illicit substance use is rarely helpful when they've just told you they're using. So, yeah, just repeat the Hep C RNA, and you are allowed to do that as a primary care provider, but you must give clinical information. So what I do if I'm rescreening after there's been a negative RNA, I write remains at risk for reacquisition. And you put that in the history. I like to actually put it in the additional tests at the bottom of the rec where you write HCV RNA. That way they won't overlook the history when the lab processes it. So the virologist gets that history, because sometimes the lab overlooks the history that you've put in. And if they get an RNA request when there's a negative RNA on file, they will reject it as not necessary. Okay, so here are your take-home messages, which is not a take-home message. Anyone RNA should be considered, with HCV RNA positive should be considered for treatment. Anyone HCV antibody positive should be considered for treatment. Hepatitis C is a common cause of cirrhosis, and anyone with cirrhosis or liver dysfunction and HCV RNA positive should be referred to a specialist. Which of those is not the take-home message? Okay. So I think there are a few people who may have tuned in a little late, but basically the answer is anyone with HCV antibody, not anyone, only the people who are RNA positive. So anyone with a positive antibody needs to be checked to see if they are RNA positive and then sent on for treatment. HCV is a common cause of cirrhosis. It is the most common cause of cirrhosis in North America, excluding Mexico. And anyone with significant liver dysfunction, cirrhosis, and HCV RNA really should be sent along to a specialist, because there are other considerations involved, including including monitoring afterward. So on that note about monitoring afterward, when people show signs of some degree of cirrhosis, typically a Medivir of definitely 3 or 4, but in some cases a Medivir of 2 if there are other, which is the ultrasound assessment of the degree of liver morphology change. If so 2 or higher, 2 if people have other risks like non-alcoholic fatty liver disease, alcohol use, ongoing ultrasound to monitor for the development of hepatocellular carcinoma is recommended about every 6 months. You will see sometimes people have a Medivir of 1 or 2, even 3, and as the years go by, in fact, their Medivir score drops. There is actually repair of some of the damage that is done to the liver over time once the hepatitis C is out of the picture, particularly if alcohol is not an issue. So, okay, yes. So here's the bottom line. So everybody, offer screening to everybody, especially if you're not convinced there are no risks. If RNA negative, decide if rescreening at intervals is necessary. So that's people who remain at higher risk of reacquisition, and because there are different genotypes of hepatitis C, antibody to hepatitis C does not confer universal immunity to every genotype, and there is some question as to whether even confers full immunity to the same genotype. As far as treatment goes, if it's positive, refer for treatment. Hepatitis support program, hepatologist. The hepatitis support program is in Edmonton is people are seen very quickly within a month or 2, started on treatment very rapidly, and so on. Referring to a hepatologist is a bit of a slower process, but the things are changing because of the DAAs. The stuff can really move along quite quickly. So make some referral one way or another. And then if there's evidence of liver problems already present, then at the very, refer to hepatology and do some ultrasound screening while you're waiting for that appointment, if necessary, and then potentially on an ongoing basis. But your treating specialist will also advise you as to what sort of follow-up is required. If the liver looks good and there are no ongoing risks, most people need no further follow-up. And I just put in a few things here. You don't have to write this down or anything. It will be included in the information and the links that are sent out to you. There's a primary care HCV pathway, which is needlessly complex, in my opinion. That's me editorializing, and not to diminish the work that people have put into it. The first part of it actually is helpful if you're trying to figure out the whole screening thing and the antibodies and the RNAs and all that sort of stuff. So the first half, after that, once you've figured out whether there are, should be referred to treatment, then just send them on. Most primary care providers at this point, there's not a lot to be gained in putting all the effort in to becoming familiar with the treatment of hepatitis C. When the number of people you might end up treating is quite low. There are some lovely posters through Katie that are free. They will be, you can order them pre-printed. They're the typical waiting room size poster, or you can download them as PDFs and print them yourself. But yes, they are free and they'll mail them out to you. Usually you'll get them within a couple of weeks. And it just says, basic messages. Anyone can have hepatitis C and not know it, and that sort of thing. There's also some brochures and stuff, patient literature that can help explain some of this hepatitis C to people. And there's also a who's at risk poster, which show, sort of this, here are the populations at risk. So that may help people self-identify. And these are the things that you can put up in your waiting room or in the exam rooms and so on if you want to. I'm not sure how you get that. It is a PDF, and so you can print it yourself, but I couldn't easily find whether Health Canada will actually send some out to you if you request them. That did not jump out from their website at me. So we have come to the end. I hope ran on a little bit longer than the last time. But I'm going to pull up.
Oh,
okay.
Sorry.
Yes. Okay. Go ahead, Mel.
Oh, no, you can go ahead if you'd like, and then I'll share.
Yep. Okay. So, do comment on reinfection, i.e. different genotypes. As I said, I mean, there's a bit of a supposition, and it's kind of hard to do these randomized controlled trials or even, good quality retrospective studies to look at whether, if someone's been infected with one genotype, say a genotype 1, are they immune to genotype 1? Do we see reinfection with the same genotype? That's kind of outside of my it's definitely above my pay grade. If Dr. Tandon is willing to weigh in on that question, she would probably give us a better answer than I.
Yeah, I mean, I guess we're using pan-genotypic regimens for the most part, I would think. So probably isn't too much of a concern, but then we can do resistance testing as well if we are concerned, or if they've been exposed to the DAAs before, so certainly, yeah, that would be something that we would take care of. Yeah.
And so I think that really the important message for people to know is that once they have been cleared or treated or cured of hepatitis C, they can still even say, well, I have antibodies. Shouldn't I be protected from getting hepatitis C again? And the short answer is no. Mm-hmm. You get hepatitis C again. So it's through avoidance of risk factors. And so here's a good question. Recommended rescreening interval for RNA individuals with ongoing risks. Recommended, sure, once a year. Or yes, Once a year that's what we do in our population, which is generally pretty highly at risk. If someone becomes reinfected on the scale of serotic change, a year is not a big portion of time. So screening every year, even if you did a screen RNA negative, a month later they become reinfected, you're still, the chances that they would suffer anything really any significant long-lasting harm from HCV reinfection within that time frame is pretty small. And then we just look at retreatment if that's a viable option. One of the questions from last week was, what about treating pregnant women? The short answer is, if you know you're pregnant, no. You wait until you're not pregnant, unless that has changed. And as I say, things change very rapidly. So Dr. Tandon, it's still don't treat until they're no longer pregnant?
Yeah, you wouldn't need to treat Hep C acutely, like urgently during pregnancy.
And there are a couple of instances where people have been on HCV treatment and then discovered they were pregnant and chose to continue with the DAAs, and no noticeable harms to the infant at all in that. But that's only a couple of instances, so you can't really base any decisions off of that at this point. But it's just recommended that, and if people are thinking about getting pregnant, not a bad time to sort of have a bit of a discussion about risks and so on. Routine prenatal testing now includes HCV in Alberta. That might be a little late, particularly if people are at risk. So if people are talking to you about becoming pregnant and so on, sure, why not? It's a cheap test and puts your mind at ease. And if you actually end up with hepatitis C, treat that puppy and then go on and have all the HCV non-infected babies you want. Okay.
I love that you're moderating your own session, which is awesome.
Status of developing a Hep C vaccine, very much in process, but there are certainly, I think have started volunteer human trials. Is that, am I making this up? No, I'm sure I heard something about it, but it's tricky. And then everybody's attention was diverted by COVID. And so, but there may be some stuff that comes out of all the work that's been done with the COVID vaccines that may actually be of use in developing of the Hep C vaccine. But as far as I'm aware, and I'm certainly not the authority on this, it is not anywhere visible. No, it's not immediately. It's not on the horizon and going to be here, anytime soon. It is still a complicated work in progress. This is an excellent question. Does leaving Hep C untreated in pregnancy increase risk for HELP or other complications? I don't think so, unless there would be cirrhosis and that sort of thing. But you would, Dr. Tandon, do you have any insight on this?
Yeah, no, I haven't read anything recently about this, so I'm not sure.
Yeah, no, and I did, many years ago, did a bunch of research about vertical transmission of Hep C in pregnancy, which just been estimated about 5%. But there was I don't recall tripping over any information about increased risks. So I think when it comes to having, if a mom is discovered, she's pregnant, has prenatal blood work, finds out she's hepatitis C positive, that can be, very upsetting, distressing, and people might actually want to talk about termination and stuff. I think, it's not up to us to make decisions for our patients, but to have a discussion, be informed, send to a specialist, including, a pediatrician or an obstetrician who's familiar with hepatitis C, has that information and can help the mom make an informed decision, because there's nothing to stop, if a kid ends up with hepatitis C, there's nothing to stop the child from being treated eventually and cured. But again, I'm not saying that I'm expert enough to tell people what they should be telling their patients. I think that's when you want to involve someone with the level of expertise required in helping people make that decision.
Yeah, and I think even last time we were chatting about the fact that we're now transplanting Hep C positive organs into people because we are confident we can get rid of it. So I think the playing field has changed now with the DAAs.
Yeah, it really is. I guess so the ultimate message is we in our practice lifetime can eliminate hepatitis C as a cause of all these of cirrhosis and liver cancer and even its effect on developing lymphoma, all the transmission, it's eliminated as an individual and a public health, an active public health concern. Is there an age limit for treatment? I don't know about at the upper end. I wouldn't say so. It's essentially no. There's no like, oh, you're too old for treatment. You would look at, if someone's 94, no evidence of cirrhosis and they're HCV positive and they're not sharing their injection equipment with other people in the nursing home, then probably you wouldn't need to do, you'd say, well, I'm not sure that that's going to benefit you in the long run. As far as the younger end of things, that is an excellent question, and I have absolutely no idea. Yeah, so the lower limit age, I don't know. If somebody pinned me down and said, well, what are the current recommendations? I suspect it would be 18 years or older. Younger than that, then that's where you get pediatric ID or gastroenterology involved. Be more often ID with peds, I think, because most kids wouldn't have much in the way of liver problems unless it was liver problems related to hepatitis C at that point. So. Okay.
Dr. Rose, I'm just going to jump in here. Thank you so much for the presentation that you just delivered. It was another fantastic presentation. And just before we say goodbye today, I just wanted to take a few minutes for everyone to sort of reflect on what they've learned today and think about how you might be able to incorporate that learning into your own practice. My name is Melanie Hetherington, and I'm an education specialist here at the Office of Lifelong Learning and the Physician Learning Program. Studies have shown that when we are thinking about making a change, we're more likely to implement that change when we write it down. And the Office of Lifelong Learning has developed a platform to help you make a personal development plan similar to a commitment to change form. And you can also earn credits for doing so. So this platform is called the MyL3 Plan. And it's a free online tool that can be used to meet and support the 3 activities or action plans required by the Physician Practice Improvement Program through the CPSA. So you can do a practice-driven quality improvement activity using objective data, which will earn you 12 credits. A personal development plan that we talked about will earn you 6 credits, and the standards of practice quality improvement activity will earn you an additional 6 credits. So the link is there if you would like to learn more. Physicians are able to delegate a support staff person to assist them in completing the cycle, and you can complete as many cycles as you'd like. So some considerations that you might want to think about when you're developing a personal development plan would be, what would you like to change? Do you have some supports or resources within your clinic that might help you? Many PCNs actually have improvement facilitators or quality improvement teams that can help support you in that goal. And then another consideration is, how will you measure that change? How will you know that you've achieved your goal that you've set out for? Another way for physicians to earn certified credits would be to do a linking learning to practice exercise. It's a self-administered semi-structured reflection exercise that CFPC members can do through their Main Pro Plus portal. And it's certified as a self-learning activity and will earn you 5 certified Main Pro Plus credits. And then lastly, we do value your feedback, as it helps improve the quality of the educational programs that we offer. It also allows us to ensure that we're meeting your needs. It shouldn't take more than 5 minutes. And as a thank you, you'll have the opportunity to participate in a raffle for a $10 Starbucks gift card. And that draw will close a week from now. And then just 2 upcoming events that I just wanted to let you know about. So the Physician Learning Program is hosting a PLP Summit on advancing practice through the power of partnership. It'll be held here in Edmonton on June 11th at the Chateau Lacombe. Our keynote speaker is Dr. Victor Montori from the Mayo Clinic. And we currently have a call for abstracts, which will close on March 15th. So if you'd like to learn a little bit more about that or register for the summit, the link is there on the slide, and we'll be sending that out to you as well. And then lastly, we do have an upcoming webinar series on updates in asthma and COPD in primary care, which begins on March 19th at 5:30 p.m. Mountain Time. So again, if you're interested in registering for that, then the link is there. And I'll turn it back over to Dr. Punita Tandon and Dr. Matt Rose for last words.
Yeah, no, thank you so much, Matt. You can take last words if you want.
Thank you everyone for showing up today. I know that was a lot of information kind of compressed into a pretty short period of time. I hope the question and answer stuff helped you focus, and that you come away with something useful. Mainly screen, and if you're not sure whether you should screen, and then if the RNA is positive, send them on for treatment.
Excellent. Thank you, Dr. Rose. Thank you, everybody, for coming. And thank you to the Lifelong Learning Program. Wonderful webinar. Take care, everybody. Have a really nice afternoon. Thanks so much, Matt.
My pleasure.